Welcome everyone to part 2 of the 2021 Leon and Josephine Winkelman Memorial Lecture. Thank you all for coming. Just a few housekeeping notes. If you are here to receive CEUs, you do need to stay for the duration of the event. We're going to be going on for about an hour. There are going to be poll questions, 4 of them, throughout the presentation. Please make sure that you respond to those poll questions to receive your CEUs. If you miss the poll, or the poll isn't working for you, just go ahead and put your answer in the chat. The chat is on for everyone to use, and we encourage participation. So before we get started, I am going to launch this poll. We are just wondering who is in the audience. So go ahead and take a minute, fill this out, let us know who's here. And just a reminder that this is required to receive your CEUs. We need you to participate. All right, now it looks like we have a pretty mixed group, similar to yesterday. Lots of people selecting that other box. And just out of curiosity, why don't you guys go ahead, if you selected other, put what that means in the chat, whether you're retired, another field in social work, or just something else altogether. So at this time, I'm going to pass things on to Robert Taylor so we can get things started.
Good afternoon, everybody. My name is Robert Joseph Taylor. I am a professor here at the University of Michigan in the School of Social Work. In particular, I am a Harold Johnson Professor of Social Work, and I'm also the Director of the Program for Research on Black Americans at the Institute for Social Research. Welcome to the Leon and Josephine Winkelman Memorial Lecture. It was created in 1978 at the University of Michigan School of Social Work with an endowed gift from Stanley J. Winkelman and his brothers as a memorial and tribute to their parents. Today we have 2 speakers. Both are assistant professors in the School of Social Work. The first speaker is Katrina Ellis. The second speaker is Jamie Mitchell. And what I like for people to do is to put their questions in the chat or the Q&A. And when you do that, please let me know who the question is intended for. If it's intended for both speakers, say both. If it's for Dr. Mitchell, say Dr. Mitchell. Or for Dr. Ellis, say Dr. Ellis. So our schedule for today is first Dr. Ellis is speaking and then Dr. Mitchell. So right now, I'm gonna take a minute to introduce Katrina Ellis, and then I will introduce Dr. Jamie Mitchell. So Dr. Katrina Ellis is an assistant professor at the School of Social Work. Her research interests include family health interventions, cancer survivorship, racial and ethnic disparities in health, and family management of chronic health conditions. Dr. Ellis conducts research with families, clinicians, and community groups, and uses both qualitative and quantitative methods. The majority of her published research examines the impact of co-occurring illnesses on the health and well-being of cancer survivors. Dr. Jamie Mitchell, again, is also an assistant professor at the University of Michigan School of Social Work. Her research examines how patient-centered communication between older African-American men, their families, and physicians can be leveraged to improve men's cancer and chronic disease outcomes and patients' experiences. She has several roles, and one of her roles is the co-director of the Community Liaison and Recruitment Corps for the Michigan Center for Urban African American Aging Research. And I just want to note at this point that this center, the Michigan Center, is also a co-sponsor of the Winkelman Lecture this year. A key component of Dr. Mitchell's research is that it includes co-managing a community advisory board and participant research registry of older Black adults at the Healthier Black Elder Center in Detroit. Her work operates at the intersection of aging, social work, public health, cancer, and chronic disease care, and health communication. So now what I'd like to do is to introduce Dr. Katrina Ellis, and she will be speaking today for about 15 minutes or so.
Well, good afternoon, everyone, and thank you, Dr. Taylor, for that introduction. It's a pleasure to be here to speak with you all today. And the topic of my presentation is cancer treatment and survivorship among Black adults and families. I'll start with some background information on cancer and caregiving among Black Americans, and then I'll talk about family comorbidity, which is the lens that I've used to examine cancer treatment and survivorship experiences for Black families. And then I'll conclude with just a few conclusions and implications for this research. If recent trends continue, it's estimated that about 200,000 Black Americans will be diagnosed with cancer this year. Age is the biggest risk factor for cancer. About half of cancers diagnosed are diagnosed with individuals aged 66 and older. It is a leading cause of death in the United States, and among Black Americans specifically, from ages 65 to 74, cancer is the leading cause of death. And then among Black Americans ages 75 and older, it's the second leading cause of death. This slide just provides some background information on cancer incidence or new cancer diagnoses and deaths by race and gender. As you can see, Black men have the highest cancer incidence rates as well as the highest mortality rates from cancer. Among Black women, we see that they have the second highest incidence rates in terms of new cancer diagnoses, but the highest mortality rates when comparing against other women of other racial groups. We also see disparities in terms of cancer survival. So when looking at all cancers combined, African American men and women have shortest survival rates. And this information on the slide just provides survival rates for Blacks and whites for the most common cancers, as well as survival by stage of diagnosis. For both groups, survival is higher when cancer is diagnosed at earlier stages. So as you can see with the localized bar graphs there, but in many instances, you also see that Black Americans have shorter survival rates compared to whites at different stages of disease. And these disparities have continued for quite some time. There have been some notable progress made in decreasing these disparities, and hopefully that will continue, but we still see these persistent disparities in incidence, mortality, and survival. In thinking about the reasons why we see this disparity, it's important to think about both upstream and downstream factors. And so the ways in which social determinants of health influence the disparities that we see in terms of cancer outcomes. And this graphic just draws attention to the influence of social inequities, institutional environments, the lived environments for individuals, and how that influences their risk factors, and then the outcomes that we see across the cancer continuum. And I'm going to focus today specifically on the treatment and survivorship experiences of Black families. After someone is diagnosed, family members and friends often step into a supportive role, and I'll use the term caregiver today. So it's estimated that there are between 1.1 and 2.8 million cancer caregivers in the United States serving in this informal role. When people have looked at some of the differences between cancer caregiving and caregiving for someone whose most prominent illness is something like dementia, diabetes, or even care for the frail elderly, there have been some notable differences. One is that the time spent in cancer caregiving may be more limited. So, an average of 2 years for cancer caregivers versus 4 years for non cancer caregivers. But the time that cancer caregivers spend caregiving is often more intense and more demanding when we think about the burden of care that they provide and hours of care per week and the types of tasks that they assist with. And some of the common tasks of cancer caregivers include helping with decision making, being an advocate, communicating with health providers and family members and others, assisting with symptom management and other medical or nursing tasks, and then providing various types of social support. So, as a first poll question, what percentage of cancer caregivers do you think provide care for an older adult age 65 or older? And as you're answering this question, I'll mention that this statistic comes from the report, which cover is shown there, Caregiving in the United States. And the subtitle is really illustrative of experiences describing cancer caregiving as intense, episodic, and challenging for many families. And so this report just provides some great information about the various types of cancer caregiving experiences that are happening within families, providing care for people with cancer of all ages. And so the answer to that poll question, which I hope you've had time to complete, is 60%. So 60% of cancer caregivers reported providing care for an older adult age 65 or older. One of the things I think about a lot in my research is cancer caregiving among Black Americans, and it can be difficult to find research that specifically talks about the caregiving experiences of Black families. And I wanted to highlight a great study that's ongoing called the Detroit Rock Study, which is collecting data from Black Americans with cancer and their caregivers. And many of those caregivers, somewhere close to 97% or so in the sample, are also Black Americans. As you can see, most of these caregivers are 50 years old or older. Most of them are also female, which reflects some of the broader caregiving literature. But one of the distinct differences that I noticed with this sample, which is going to be very interesting to hear more about, is that only 42% of this sample of caregivers are spouse or significant other, and they also have adult children and other family members well represented. In many of the studies that we see in cancer and caregiving, the spouse or significant other relationship represents around 70 to 75% of what we normally study. And so this study will provide some important information moving forward about how we support different types of family care relationships. We also know that employment and financial related challenges are common when someone is diagnosed with a serious condition like cancer. And in this sample, they found that 73.8% of caregivers reported making changes to their employment to provide care. One of the other main things that I like to think about in my work with families is the health of caregivers themselves. And we know that in addition to the disparities that we see in cancer, many other chronic illnesses are of concern in Black American population. So things like high blood pressure, diabetes, other chronic conditions happening at higher rates among Black Americans and being diagnosed at earlier ages. And this graphic just shows a snapshot of some of that chronic disease burden, which for me leads to the question of what other health concerns are caregivers managing when they're stepping into this caregiving role for someone who's been diagnosed with cancer? And this is where the family comorbidity lens comes into play. So, family comorbidity has been defined as the presence of multiple co-occurring physical and/or mental health problems in families. Often, when we think about comorbidity, it's at the individual level. So, when someone is diagnosed with an illness, we think about the other conditions that they're managing or their comorbidities, or maybe multimorbidities, so multiple health conditions that someone is dealing with. But family comorbidity looks at that at the family level and thinks about the family unit and the conditions that may be within the family system. And this represents to me a better representation of the lived experience of health within many families. So, some colleagues and I were interested in understanding research that has documented health conditions among multiple family members. And so, we did a systematic review to see the degree to which studies had even captured chronic conditions across multiple members of a family system, even if they didn't use the word family comorbidity. In our review, we found about 114 studies that provided this family level chronic disease information. Surprising to me, only 12.3% of those studies included someone with cancer, and we could only find 16 intervention articles seeking to address the health outcomes of family from this perspective. And of those, only 4 included someone with cancer. And so there are many opportunities, I think, to think about expanding and building on this work. One of the ways that I've done that more recently is with some funding from the Michigan Center for Urban African American Aging Research and doing some secondary analysis to understand the symptoms that people with cancer are experiencing soon after diagnosis, Black Americans specifically, and also their caregivers, just to get a sense of what are the health needs at the time, near the time of cancer diagnosis and when treatment is starting. And I've also wanted to know the degree to which the symptoms that each person is experiencing influence their quality of life. So things like pain, fatigue, nausea, that the person with cancer has been diagnosed is experiencing, and I'll refer to them here for this analysis as patients, and then also their caregivers, and how their symptom distress also influences the quality of life of the other person. And so for this analysis, I have a sample of 151 Black Americans who've been diagnosed with cancer and their caregivers, or dyads. We have a measure of 13 symptoms. So, and 12 of those symptoms are physical health symptoms, one item measuring mental distress, and then a quality of life measure, which assesses various dimensions of quality of life. So, people's physical, social, emotional, functional, and then overall quality of life. And when this quantitative analysis, we do actor partner interdependence modeling to again assess the degree to which someone's own symptoms influences their own quality of life, and then how someone's symptoms influences the other person's quality of life. And I'll start with the most prevalent symptoms that we found in this analysis. So among patients, fatigue, pain, sleep, weight loss, and mental distress were reported among at least 50% of those in this sample. And we see the same common symptoms among caregivers, but just in a different order, with fatigue and sleep and mental distress being the most common symptoms among the Black caregivers in this analysis. And when we combine the symptoms together to also include their reports of how severe the symptoms were and how hard it was to manage them, we get a score of mental distress, physical distress. And we found that physical distress was higher for patients and caregivers, is to be expected given the cancer diagnosis and treatment. But we didn't see any differences in the level of mental distress between the person who was diagnosed and their caregiver. And when thinking next about how symptom distress influences quality of life, the broader trend that we see is that more mental distress or more physical distress was associated with poorer quality of life across many of the dimensions, as you can see. There are some instances where we didn't see that association, but broadly speaking, more physical distress was associated with a person's poorer quality of life across many different dimensions. And thinking about partner effects, we saw that more physical distress for patients was associated with poor emotional quality of life for caregivers. The same association for caregivers, so more physical distress for caregivers, poor emotional quality of life for patients. Also, more mental distress for caregivers was associated with poor patient overall quality of life. And then a surprising finding that more physical distress among caregivers associated with better patient social quality of life. So that was a surprising finding for us. Overall, I think what this data shows is the degree to which symptoms of both patients and caregivers influence their own quality of life, and then in some instances, the other person's quality of life, and really points to the need to think about symptom management, not only for the person who's been diagnosed, but also that person who's stepping into that important caregiver role. I've also been thinking about family comorbidity after someone completes cancer treatment. So, for those who are able to complete cancer treatment, what are their experiences like during that period of cancer survivorship? We know that there are over 1 million Black Americans with a history of cancer in the United States. And for those who transition from treatment, so thinking about surgery, chemo, radiation, it can be a big time of adjustment. They may be coping with side effects from treatment, having concerns about cancer recurrence. And for many individuals, having questions about, are there things I can do to improve or maintain my health after going through the cancer experience? And then also thinking about the degree to which those people who've been diagnosed, who have been receiving care, are also stepping back into or stepping into caregiving roles themselves. And so, for a second poll question, thinking broadly about caregiving in older adults, what percentage of older adult caregivers age 65 or older do you think provide unpaid assistance to 2 or more adults with health or functional needs? And this statistic comes from the report Caregiving in the United States, which provides a nice profile of caregiving in the United States for many different conditions. And what I like about this question is it draws attention to the fact that many people in caregiving roles support more than one individual, even though in the literature we think about it often as just a single caregiver and care recipient. And so for this question, this provides information about the degree to which older adults themselves are serving in these multiple caregiving roles. And the answer to this question, hopefully you've had a chance to respond to that, is 20%. So in this report, 20% of people aged 65 or older reported providing care to 2 adults with health or functional needs, 2 or more adults with health or functional needs. And so, in thinking about cancer survivorship from a family comorbidity perspective, and thinking about how can we support people who've gone through this cancer experience with doing things that they feel will be supportive for promoting and maintaining their health, often we talk about physical activity, nutrition and diet, weight management as things that have been shown to assist with quality of life and managing different symptoms like fatigue, for example. And so, in a recent review, colleagues and I wanted to know the degree to which interventions had focused on these important health behaviors, not just in cancer survivors, but also in a family member as well, recognizing that the family member themselves may have health needs and everyone, for various reasons, benefits from physical activity, nutritional diet, and healthy weight management. And so we found 14 studies that focused on improving the health of both cancer survivors and a family member. Many focused on a combination of diet and physical activity or weight-related outcomes. Only 2 of the studies were focused predominantly with Black American samples, and it was often unclear the degree to which family members had their own health conditions that they might have been managing, and if the interventions were successful in improving the outcomes, not just for the survivor, but also for family members, because even when the interventions targeted both individuals, the data reported often focused just on the cancer survivorship. So many opportunities to think more broadly about improving the health of the whole family. And so related to this, an ongoing study that I'm conducting called Facing Forward is conducting interviews with Black Americans who have completed treatment for early stage breast or colorectal cancer and a family member that they feel is supportive of their health. And we're talking to them about their adjustment after completing treatment and moving to post treatment support, things that are helpful for the family in promoting and maintaining their health, some of the challenges that they face, and some of the supports that would be helpful. We are finding significant levels of family comorbidity. So the survivor, the family member talking about managing multiple conditions and other family members managing conditions as well, and the ways in which that influences the family's orientation to health and the things that they do to support each other. We're also seeing these care systems, so the survivor providing care to multiple people, receiving care from multiple people, and within the family, these systems of care to support one another, which is often not reflected in the literature in this area. And so to wrap up with just a few implications, I think that a family comorbidity perspective is really useful for reflecting the lived experiences of families who are often managing many health conditions at any one time, even at the time of cancer diagnosis. And this perspective could be informative for providing supportive programs to survivors and families and others in their network. There are some known challenges to supporting cancer caregivers. So a lack of systematic cancer caregiver assessments, disparities in referrals and supports provided to cancer caregivers, a lack of reimbursement for working with caregivers. And so many opportunities to think about how we can improve programs and policies to support those in these caregiving roles. And then lastly, ways that we can build upon family strengths. So families who have been managing multiple health conditions, often over many years, have a number of important strengths that we could tap into and work to enhance as we support them through the management of cancer, cancer survivorship, and these other significant illnesses. And so I just want to thank my research team and collaborators and funders, and of course, the families who participate in this research. Thank you.
Hi, everyone. My name is Jamie Mitchell, and I'm going to be talking about engaging Black older adults as participants and partners in research to advance health equity. Next. So first I want to highlight just a few concepts that we often throw around, concepts about differences in health. We hear a lot about health disparities or types of health differences that are linked with one's economic, social, or environmental disadvantage, but we also hear the term health equity a lot. And when we're talking about health equity, we often mean equal access. So equal access to healthcare, for equal need, equal care, of equal quality of care for those who need it. And so these two terms are actually not quite the same, but in relation to one another. So I like to think about health disparities as a way to measure our progress toward health equity. When you think about health equity, think about social justice for health. And when we think about inequity, we often use terms like things that are unnecessary, unfair, and unjust. So I just want to use those terms to kind of break it down. I'm going to be using those throughout the presentation. So when you hear inequity, think about unnecessary, unfair, and unjust. Next. So when we talk about the history and conditions that lead to mistrust and underrepresentation in research, these are unfair, unnecessary, and unjust conditions and historical events and narratives. So what are some of the reasons why people of color more broadly and Black older adults in particular tend to mistrust participating in health-related research? Well, obviously we have a strong history of historical research abuse. We think about the Tuskegee syphilis studies. We think about what happened with Henrietta Lacks. And these narratives are still very much being discussed. However, I also want to highlight that mistrust often stems from current negative experiences or personal negative experiences with healthcare and health providers. So someone has gone to the doctor's office, they have felt as if they were being talked down to or weren't being paid attention to. And those also contribute to mistrust and to a feeling that you won't be taken care of if you participate in research as well. There's also a number of other reasons why people don't engage in research, even though it's incredibly important that we have representation of diverse populations so that we know that our science will apply to multiple populations. So for example, some folks may not be aware of opportunities to participate and they might be willing if they knew more about it. Many are fearful of reinforcing negative stereotypes in terms of what will come out of the research, particularly around race and ethnicity. Some are very concerned, and rightfully so, about how their biological or demographic data will be used or whether it will be exposed in some way. Others expect disparate treatment based on their race or socioeconomic status. And again, that is very tied to what we know as a history of research abuses. Many have competing demands, so they would participate if not for caregiving, the need for transportation, the need to work, and others fear unintended outcomes or being experimented on, or profit motives even of researchers or industry, which we see quite a bit in some of the vaccine trial discussions that we have going on right now. Next. So this is just a screen grab from a recent article about historically Black colleges and universities, which have stepped in to try to bridge some of the medical mistrust amongst people of color more broadly and the Black community specifically. And this is specifically around COVID-19, but this raised an interesting stat out of this article from ABC News, and that was that across all disease types, so cancer, chronic disease, any condition for which there are clinical trials going on, Black people represent 13.4% of the US population, but only 5% of clinical trial participants across the country. So of course, it's very challenging to level the playing field for Black people and to have them involved in medical research advancements because they're not at the table. And so this article kind of goes on to say that medical establishments have to do better, and there are many efforts that need to be undertaken, such as retraining faculty and staff to think specifically about Black patients and treating them with equity in every sector of society. Next. So the short of this is that when Black people are not at the table for research advancement, right, when they're not included in research, and this is research that could improve health, could improve quality of life, It's unfair, it's unnecessary, and it's unjust. So it's inequitable. We want to know that when science is happening, when not only drug trials, but also think about prevention trials, right? Tobacco cessation, diet and exercise, anything that could lengthen the life of Black people, Black older adults, could improve their quality of life, could support them and helping them live longer, more quality lives for their families. We want them to be included so that we know that the science coming out of universities and hospitals applies equally to Black older adults and Black people in general. And so we want to bring more equity to that work. Next. So I want to just introduce the Michigan Center for Urban African American Aging Research, because we're doing some of this work. And I'm going to use some of the work that we're doing with community members as a case study for some of the lessons that we're learning about how to partner with Black older adults in the community to improve equity in research representation. So MUCWAR, or the Michigan Center for Urban African American Aging Research, try saying that 3 times fast, is a collaborative research effort that's been going on since about 1987. And it's between the University of Michigan, Wayne State University, and Michigan State University, excuse me. So this collaborative is funded by the National Institutes of Health, and they have a multi-part mission to support underrepresented researchers who are interested in aging, to provide health and social programming for Black older adults in the community, and specifically to increase research participation among Black older adults. And that's where I come in. So I want to talk more about that. Next. So this is just a little diagram that kind of shows how all of our organizational components kind of fit together, how we're funded. But I want to highlight one key piece, and that is that we are really driven, our community side of this work is really driven by a community advisory board of Black older adults. They are a part of our Healthier Black Elder Center, which is our community initiative out of this multi-university partnership. And we're physically located on the campus of Wayne State University in Detroit, in the Institute of Gerontology, but we do work that really impacts the entire region. And our community advisory board has a lot of functions. This is about 18 Black older adults who come together quarterly, and they help to put on programming, community health programming for fellow older adults in the Southeast Michigan region. They help to drive a participant research pool, also called a registry. You might think of a research registry. And these are about 1,000 Black older adults who volunteer regularly for non-invasive social science and health research. So they help to coordinate that pool. They also review research applications and undergo and provide training for researchers. And they also provide a consultation service more recently for researchers who want to engage more with Black older adults, and they provide their expertise and perspective on all aspects of the research process. Next. So this is just a few of our wonderful members of our advisory board, as well as our community outreach specialists there, and some of the other faculty co-leaders as well. And so I just wanted to kind of shout them out and give them a little shine. We also have a Flint Healthier Black Elders project that has just gotten up and running, and we have a community advisory board there as well. And hopefully we'll get, after when we're able to meet in person, hopefully we'll have a group picture to share next time. Next. So I want to talk a little bit about some of the lessons that we've learned from doing this work. And again, this project, this collaboration amongst universities to do this community outreach around research representation with Black older adults has been going on for over 20 years. Our CAP members have changed over the years, but we have some long history in the community, and we have learned some of these lessons over a couple of decades of doing this work of promoting health equity in research participation, specifically with Black older adults. Next. So the first lesson that we've learned and that we continue to live by is that we're very transparent about who we are, what we do, and also what our ask is of the community, right? So we come right out when we meet someone and we want them to join our research registry or attend our events, and we say, hey, our core goal is to encourage older African-American adults to really think about the importance of participating in research. And we educate them. We talk about why research is critical to understanding why it is that certain populations, including Black older adults, are at a higher risk of developing certain diseases and why they have a greater impact on their health and longevity. And we believe that by being transparent, that is one of the ways that we build trust, and that we get people on board with our mission. Our next lesson is really, we think about what's in it for the community. Whenever you're coming in and you are working with a new community, you're trying to establish trust with this community, you don't want to simply come in asking for things. You want to provide a service, right? And so one of the main ways that we serve the community is through our Lunch and Learn events. And HBEC simply stands for Healthier Black Elders Program, or Healthier Black Elders Center. And so we, before the pandemic, before all of the social distancing, we would provide 8 to 10, so nearly every month, we would have something going on in terms of an educational event. And these are various topics that are relevant to older adults, and the topics are also driven by our advisory board. In times when we were together, we provided free lunch, and we would have health organizations or student medical and nursing organizations come in and provide health screenings like blood pressure and eye checks, which were very valuable to the community. We also provided in-person opportunities for our community members to hear from researchers and to sign up for research studies that had already been approved and vetted both by the university and by our advisory board. Next. So this is just a quick screen grab of some of our programming that we've done. This was from this past fall of 2020 when we went virtual. So we've had programs like Stocking a Smarter Pantry, COVID-19 and flu season, coping with grief and loss, which is particularly relevant, talking about skincare as we age. And we've, of course, transitioned to Zoom, as many of us have for these events, but we also provide a dial-in number. And we also are able to send out printed instructions on how to dial in or access Zoom via a device. So we really try to make these events as accessible as possible, as well for folks who have the internet, as well as those who just want to listen in. Next. I'm really proud of our MSW interns at Wayne State University, because we have interns both at Michigan and at Wayne State. They innovated something called the Party Line. This is a social group for older Detroiters that just got started this past fall. And they have a really vibrant group of older adults who join, who call in every Tuesday from 1 to 2 p.m. It goes for the entire semester. They talk about recipes, they play games. It's just an opportunity to combat social isolation. And so I'm really proud of our interns for innovating another service to the community that really meets a critical need. Next. The next lesson that we have learned over about 20 years, long before I came on board, the last decade or so, but another hard-fought lesson that we've learned is how important it is to acknowledge and confront the stigma of research head on. And so we know that there's a troubling history of medical research and research abuse for Black Americans, for Black older adults, that many of them this is fresh in their minds, that these discussions are still being had. And so we talk about this. We take time to dispel myths, to acknowledge the research protections, for example, that have emerged out of this troubling era, and to talk about just this historical narrative and the differences between now and then, and what we can assure them of in terms of their research participation. And so we don't hide behind this or sweep it under the rug. We certainly talk about it head on. And these are conversations that the older adults in our community are interested in and excited to have. Next. Our next lesson is that we try to really be a bridge to positive and trustworthy experiences, right? So again, we have a research registry or a pool of over 1,000 Black older adults. We connect them to research studies that have been double vetted. So they've received their university level institutional approval, but they've also been approved by at least 2 members of our community advisory board who have received special research training to review the ethics and the applicability of the research to Black older adults in particular. Those participants who would like to join a study, it's always voluntary, they're simply referred. And again, we continuously provide a research toolkit specifically for our advisory board members so that they feel comfortable evaluating the quality of the research studies who reach out and want to access this registry. Next. So this is just another screen grab from one of our quarterly newsletters where we actually are advertising some of the many studies that are actively pulling samples of Black older adults for their studies from our research pool. So we have topics such as cognitive capacity, searching for health information, cognitive loads and gait performance. We have mobility. We have community-based approaches to identifying cognitive impairment. So there's a lot of cognitive studies going on. Also living in Detroit and healthy aging. So we're we have great partnerships with researchers at all of our local universities, and we encourage researchers to think about having more equitable research representation. And then we provide this resource of a community group waiting to engage with them who are knowledgeable about research and looking forward to contributing their perspective or voice or knowledge about their behaviors or life to this work so that we know that the research that comes out of these studies has included Black older adults. Next. One of the last lessons is that engagement is ongoing. Engagement is hard work when it's meaningful, when it's authentic, but it is so incredibly worth it. So again, not only do we do events 8 to 10 times per year, but we also send out a quarterly newsletter to our over 1,000 Black older adults and also our community partners and aging organizations that we work with in the Detroit metro area. We conduct a retention survey every year and a half or so. We emphasize the safeguards of research, and we also make sure that anything that we approve has been properly vetted. We're also putting out articles, so we're publishing in the scientific space about new approaches for educators and researchers who want to engage with Black older adults. And we're constantly soliciting community feedback and creating new programs that support the health of Black older adults in Detroit and also now in Flint and their families. So we are a collaborative group. We're constantly working with other aging-related organizations, and we try to really be accountable and provide constant outreach in many different capacities to the community that we serve. So this engagement work is hard work, but it's also really valuable work that builds trust and brings more Black older adults into the research enterprise. Next. Finally, it's really important that we share what works and that we continue to build on the model that we are operating under around equitable research representation. So for example, we currently have a new grant in Flint, Michigan that I am the leader of, recruiting and retaining African-American older adults into research, or ROAR. We are using Detroit, the work we've been doing in Detroit, as a model and tailoring it to the Flint area. And we now have a new advisory board in Flint of Black older adults. We're getting ready to launch our own participant research pool or research registry of Black older adults. And they are really excited in the Flint community to know that services, supports, and research is going to be in the forefront that specifically represents Black older adults. And so we don't think we're going to have any problem seeding a brand new research pool and also connecting with researchers and encouraging them to include Black older adults and partner with us in our registry. Next. So in summary, if we're thinking about, what would be a template, from working with healthier Black elders in Detroit for more equitable research in aging, I would definitely say that trust is the foundation of everything that we do. We're present. We don't just host our own events. We also show up at other events. So when we're invited to community consortiums, community meetings, we network with stakeholders. We offer our own support when other groups, community groups reach out. We show up, right? We're present. We're a part of the community that we work in and serve, and that we're asking to come to the research table. In times before COVID, we definitely went to where the people were. Now everything is virtual, but we're also mindful about how to make everything that we're doing, whether it's events or research recruitment, as accessible as possible. We want to involve and partner with participants at every step of the process. So that means using community advisory boards, accessing and working with community groups. We know that our advisory board members and others in the community who are interested in research have a lot to offer, a lot of knowledge rather, to share about how to best serve or best think about Black older adults at every aspect of the research process, from engagement, design, sampling, how research is presented after the data is collected, the benefits and harms. And we want to hear participant and community voices, not just at the end, but at every step of the research process. And we really encourage that. And then finally, we really encourage researchers who work with our registry or pool members to disseminate what they find back to the community. So we say, don't research and run. People who participate, our older adults who participate, they want to know that their participation made a difference. They want to find out what happened after I, provided my information or I participated in that study. And so we encourage researchers to find a way to put their findings into accessible formats, into lay format, and participate in a community consortium, create a pamphlet, create a PowerPoint, join one of our community groups, and present their findings and close that cycle, that feedback loop about research. Next. So my poll question is true or false? Gaining the support of trusted stakeholders, such as community or faith leaders, significantly improves the willingness of Black older adults to engage in research. Next. So I just want to say thank you. I'm always happy to share more about the work that we're doing at the Michigan Center for Urban African American Aging Research and the Healthier Black Elders program in Detroit and Flint. And funding for this work, again, is provided by the National Institute on Aging. And that's how you can reach us on Twitter and on the web and in all of the different places. Thank you.
All right, thank you, Dr. Mitchell. So if you can just stay on the screen.
Again, good afternoon, everybody. And I want to thank both Dr. Ellis and Dr. Mitchell for great presentations. I'm going to start right now with a few questions. And many of these, and most of these are from people in our audience today. And again, if you have any more questions, please put them either in the Q&A or on the chat. So number one, this is for Dr. Ellis. Given the challenges involved in cancer caregiving and the large number of people providing it, I am wondering about your thoughts on the use of technology to help family caregivers improve their caregiving skills and to help them with the stress related to the work that they do.
Yeah, that's a great question. Thank you for asking that. I think that there are many ways we can think about leveraging technologies to support cancer caregivers. And it's important that we think about the technologies that would be most accessible to caregivers. It's interesting that before the pandemic, I did some research with rural Black Americans in North Carolina to talk to them about ways in which we might use technology for a cardiovascular disease related family intervention. And many of the older adults talked about the fact that, use of internet, smartphones wasn't something that they would prefer to do. They would prefer to do something a bit more simpler. And then other studies that I've done more recently have used telephones to connect with older adults. And so it'd be interesting to see how the pandemic has shifted some of that for our populations and thinking about comfortability with using the internet and Zoom and other things. But to get to your point, I do think that there are many opportunities to use technology to support caregivers in enhancing skills, providing emotional support, helping with any distress that they may be feeling. And it's also important to support caregivers in taking the time to focus on their own health, which can be challenging for many caregivers when they're in these roles, feeling that they don't have the time to focus on themselves when they're caring for other people. But I do think technology would be a great way to continue reaching out to cancer caregivers.
Thank you. Dr. Mitchell, what are your thoughts, impressions about the apparent disparity related to the COVID-19 vaccine distribution?
We've been talking a lot about that in our Flint advisory board in particular. And I think every area is different, but this is, it's disappointing, right? Because we know that one, I think there's this narrative, one, that Black older adults or that Black people in general in mass are hesitant to take the vaccine. But we have some really good data coming out of Kellogg Foundation and other places that shows that when it's broken down by kind of demographic, by education, by income level, by different different demographics, that there is a larger proportion of Black older adults in particular who are interested in taking the vaccine if it's accessible and when it's accessible, and are waiting for their turn. And so I think it's disappointing, of course, that our kind of national distribution, our local distribution doesn't quite have it together. And I'm really hoping, as many of us are, that improves very quickly, because I know from the numbers and also just colloquially from working with my advisory boards that there are many folks, many Black older adults who are anxious to get access to the vaccine.
Thank you. So for both of our presenters, just based on the number of questions that we have and the amount of time, I'm gonna just ask you now to do very quick responses, okay?
Okay.
So Dr. Ellis, do you know any research, or have you studied this impact of cancer on wealth, or the financial burdens on cancer, especially among poor families?
It's not something that I've studied a great deal in my work, but I do know that the financial impact is great. Financial toxicity is an area of research that a lot of people look into to understand the ways in which this cancer diagnosis and associated treatments just can have a devastating impact on families' finances. People having to take off from work and not receiving payment, changing employment situations, decreasing hours, and so it is a really pressing issue and an important one for a lot of families.
Absolutely. If I could add a resource, Dr. Taylor, Dr. Manal Patel in the School of Public Health here at Michigan has a large grant and does work in the area of financial hardship and cancer.
Thank you. This is for Dr. Mitchell. Negative research experiences, both current and historical, continue to be at the top of the minds for many African Americans. Think about all the things you and your colleagues are doing to positively engage Black Americans in research. What are you most excited about? Do you have any new ideas that you want to share?
Absolutely. So I'm most excited about the work that we're doing in Flint, expanding to new places where the attention has been on younger children, on other populations, but has not been on older adults. One of the things we know is that Black older adults have so much life experience and wisdom to share. They're often excited about the opportunity to engage in research. And so the work that we're doing in a new city where we don't have this research infrastructure, we haven't been there for 25 years, starting something fresh from the ground and getting the community's voices right at the start. I'm really excited about that.
Okay, give me 1 second. I'm just looking over the questions. So this is for Dr. Ellis. In terms of impact of cancer on families and on marriage, generally speaking, and we know these are nuanced questions that deserve a nuanced answer, but to the degree that you can say something somewhat quickly, what's the impact of cancer on marriage and family relationships? Do they make the bond stronger or weaker?
That is a difficult question that does require some nuance. And I think there are many different dimensions of relationship quality and functioning that we could think about. So, communication, support, even the effectiveness of support. And it does vary within families. And I think that we also have to keep in mind that the cancer experience itself can feel like a bit of a roller coaster. So, ups and downs, highs and lows that families navigate, and times in which things feel really hard and harder to connect and work together than times when things feel more in sync. And so I think for many families, it does have an influence, and that the influence that it has in families is not only during the cancer experience, but even after it as well. There could be some challenges with even finding the space to process what happens after you have gone through that experience. And one of the things that families in our current study have been telling us is that they just appreciate the time to just share and talk about things that they hadn't processed yet as it relates to what happened with them and their family and their relationships. And so I think there are opportunities to support families in having those conversations just to process things and move forward.
Thank you. So I have a question that I will answer because I think I'm probably a little better suited for this question, which is I work as a hospice chaplain, and I wondered what effect spirituality and spiritual activities have on the African American community and how that compares with other ethnicities. And since that's my area of research, what I'll say is number one, African Americans have the highest levels of religious participation of any other group in the country, any other racial or ethnic group. Number two, older African Americans have higher levels of religious participation than younger. And among those groups, women have the highest levels. So by far, the most religious group in the country are older Black American women. I hope that's helpful. I'm trying to remember, I'm sorry, with Dr. Ellis, did you get the last question?
I did.
Okay. So Dr. Mitchell, can you give me an example of like a number one, like a challenge or difficulty that you've had in terms of working in the community?
Absolutely. I would say that challenging some of the myths around research participation, I think that I give a lot of community talks. I work with a lot of different groups, and I think that folks are not aware sometimes of how much things have changed from the historical narrative to the current day. And so, we have so many research protections in place that, this is not general kitchen table conversation, right? People don't sit around talking about institutional review boards and, research ethics. And so a lot of times those narratives get passed down and there's certainly truth to them, but at the same time, a lot has changed. And so we do a lot of work to dispel myths, to bring people up to date about how they are protected, how they can quit at any time, how everything is voluntary. Both the science and the ethics have been reviewed multiple times. And I think we also do that work by only allowing our participants to engage in studies that we know are ethical, that we have approved, that our community advisory board has approved, because that goes a long way in dispelling those myths when what they see is high quality. But yeah.
Thank you. This is for both panelists. How do you promote your research to a larger level? And so we'll start with Dr. Ellis and then with you, Dr. Mitchell.
I think it's important to connect with the community immediately surrounding me. So in thinking about the work that I'm currently doing, thinking about keeping connected with the participants in the research, not just during the study, but afterwards. So making sure that I routinely share findings directly with the families who I've been engaging with, provide them with opportunities to work with me as a community advisory board member, or connecting them to other resources within the community. In addition to putting out papers and doing presentations, I like to find ways to engage at a more regional level directly with families in different community settings.
Thank you.
Yeah. I concur with Dr. Ellis 100%. My work has increasingly been more in front of community members, though we're still writing the papers and writing the grants behind the scenes, but we show up at community groups. We got invited to one in Flint that was actually a cancer action council that was specifically focused on community members' concerns about cancer. I pop in and answer any of their questions that I can. I've done work with Black men in HBCUs talking about cancer concerns. And so I find that just being accessible and available to share my expertise and to disseminate what we know is good science is one of the best ways to be out there, out from behind the ivory tower, if you will.
And Dr. Mitchell, this is a question for you again. What are the kind of things that you've done to recruit Black men in particular into research?
That is a constant work that I am doing. It's a component of the grant I'm working on right now. So we have partnered, you hear oftentimes, working with faith communities, working with barbershops, but we're also working with the alumni of fraternal organizations to engage them as well. finding older Black men. Many of them are online, digital spaces, larger workplace programs. So we are working really hard to do, even on the website that we're building for our work in Flint, there's a spotlight on Black men's health that we're building there. We're hoping to attract some eyes as well. So we're working both in traditional spaces that you often think about, barbershops and things like that, but also trying to think outside the box about where to find older Black men engaged in leisure and community and civic organizations, workplace organizations, and connect with them.
Thank you, thank you. I have 1 or 2 comments that I'm going to read from people because other people may not see these. I'm not sure. One is just to mention about the recent Black church documentary on PBS that was on last week, but it is streaming online, so people can watch that. The second thing is Dr. Peter Lichtenberg, who's at the Institute of Gerontology, is also one of the directors of the Msw Center. Does a lot of work on older adult financial vulnerability. And I think those are the other 2 things. I think that is about it in terms of questions. Let me just check and see if I got another one here. One is, and I guess this is for both people. Have you considered working with unions, particularly the retirees in unions?
That's fascinating. I haven't yet done any work in that space, but I definitely would be interested to hear more about it, because it sounds like, particularly I'm thinking about the auto unions, things like that. It seems like it would be a really fruitful space to expand research participation with Black participants. So thank you for that suggestion.
I agree. Same response as well. I think the potential opportunity there that I have not explored.
Yeah. And I'm going to encourage both of our panelists to look at the Q&As and the chat at some point, because some of these are specific questions. Things like, can I be involved with the Msw? Can I be involved with this? And so that will, require a specific answer.
Will do. And yes, you can always be involved with Msw. I'll just throw that out there. Check us out online. Yeah.
Yes, absolutely. We have an active Twitter page, and we also have a website. And also you can contact either me or Dr. Mitchell. So again, I want to thank our panelists. Again, this is the part 2 of this year's Winkelman Lecture. We are very happy that we've had roughly maybe 140 participants this year. And so we're very thankful that you've taken the time to do a little joint learning with us. And again, thank you very much, panelists, and I hope everybody has a good day.